Well, what does that mean?
Hi, everybody. I'm Dr. Carolyn Alexander, and my partner, Dr. Mark Surrey, is here with us. We're excited
Hi, guys.
for this webinar today to talk about preserving your fertility, the ins and outs of egg freezing. Next slide. Dr. Surrey's our co-founder and medical director, and he's been an amazing mentor and colleague for many, many years here at Southern California Reproductive Center. He serves as a clinical professor in the Department of OBGYN at UCLA. He teaches all the fellows from both UCLA and Cedars-Sinai, and he's extremely dedicated to all his patients and to provide the best care. We're always staying at the cutting edge here and working hard to help every patient have an individualized care plan. Next slide. I'm born and raised in Los Angeles. I went to UCLA. I lived on the East Coast for a little bit and then came back to LA. And I've been here working with our embryology lab now since 2007. So it's been such an honor and a privilege to be a part of such a great team. And I'm looking forward to any questions you guys have. We're happy to answer them at the end, and looking forward to meeting anybody that wants to discuss their fertility, talk about hormones, check on how their overall reproductive health is going. Next slide. SCRC has a proven track record. We have more than 25 years of experience. Our state-of-the-art embryology lab, our surgery center is right here in our unit, and we have offices in Beverly Hills, Pasadena, and Santa Barbara. Our lab has experienced and certified directors, double witnessing verification system. We do flash freezing or vitrification. We were one of the first centers on the West Coast to vitrify a blastocyst, which was really cutting edge and state of the art. We do blastocyst biopsies for pre-implantation genetic testing for aneuploidy screening, as well as genetic single gene disorders, autosomal dominant disorders, X-linked disorders, specific genes that may run in your family. It's important to think about it and talk to a genetic counselor. We also are available to do sex selection if that's your family building goals. We have an embryoscope or morphokinetic analysis, which helps in some situations, helps us understand an in-depth view of how the embryos are developing. Next slide. Today, we're going to talk about the patient evaluation, a detailed history. Really important to understand your menstrual cycle. When you come to the fertility doctor, you want to be prepared with any prior blood tests you've had, any evaluations you've had. We talk about preparing your body for fertility, the fertility journey. We talk about age factor, and I started having kids later in life too, so I understand the age factor very, very well. And we talk about egg freezing, egg and embryo freezing, as well as our success rates. We'll meet our team and any special offers, and we're happy to answer any questions. This image is our other partner, Dr. Dancer, and there was an image of Dr. Susan Maxwell, our wonderful reproductive endocrinology and infertility specialist in Santa Barbara as well. Next slide. So thinking about the medical history, it's important to understand your periods. When you went through puberty, we talk about the menstrual flow, whether you have really bad cramps. That is a clue sometimes for inflammation and different issues such as endometriosis. And it's important to make sure your medical history is up to date for your annual pap smear if you're over 40 or have a family history of breast cancer, to talk to your doctor about any imaging such as mammogram or breast ultrasound. It's important to have your annual physical exam to do an annual checkup for overall health. And we do a physical exam to do a pelvic ultrasound, your vital signs, we check your thyroid, and we want to make sure we're looking at everything very carefully to provide a direct and individualized care treatment plan. The diagnostic testing is, we're going to go into it in a moment, but it involves, I always call it the eggs, the sperm, the fallopian tubes, and then understanding your uterus. And so we try to really tune into any health issues overall, as well as specifically your gynecological issues. Next slide. So AMH is called anti-Müllerian hormone. It's produced by the granulosa cells around the egg, and that is a reflection of egg supply. For certain age groups, there's special normal AMH ranges. Don't be too alarmed if your level ends up being a little lower than expected. It's never been used as a predictor of who will get pregnant. It's used as a predictor of response to the medication protocols that we use for fertility treatments. And so it's important to balance that and to understand that. But for age 26 to 29, we want it 1.9 to 5.8. When you're 30 to 35, 1.4 to 4.2, and 36 to 39, 0.8 to 2.8. But even at that age, we're really hopeful that it'll be above 1 or even above 1.5, because that's more of an average that we're hoping to hit. And 40 to 44, it tends to go down over time as a natural ebb and flow, but normal is 0.4 to 1.4. And then over 44, we see this commonly where the AMH is 0.14 to 0.42. But in that patient population, there are some outliers where the AMH is exceptionally good, and we can have an open discussion to think about the pros and cons of all the options out there for you. On the pelvic ultrasound, it's a transvaginal ultrasound. The ovary looks for a moment like a chocolate chip cookie, and each follicle, which is each circle there in this image, has a potential egg, hopefully. And so when we count the follicles, we're hoping to see 5 to 10 on each ovary. Sometimes we'll see more on one side, and it's important to think about vascular flow, exercise. So if you're not doing as much cardio, we encourage you to amp up your cardio. Sometimes in some situations, it can be a clue also for endometriosis or any prior surgeries that you might have had, such as laparoscopies or cyst removals on the ovary. So it's important to think it through with your doctor. Next slide. Semen analysis is really, really important. Some of our patients get to us and they're really frustrated. They've been trying to get pregnant for over a year and we haven't gotten a semen analysis. And then when we do it, check it, it's unusually low, and that could have been detected maybe a little bit earlier. So if you're at 35 years old, we don't want you trying for too long without detecting the egg supply level, the fallopian tube test, and the semen analysis, so that we can get an overview of how your reproductive health is going. But with the semen analysis, we ask the men to ejaculate 2 to 5 days before their appointment, so that we can get a reliable motility. We want the volume over 2 milliliters, the concentration over 20 million per milliliter, motility over 50%. The morphology is the shape of the sperm. So this image is a normal sperm here. And then as you can see, abnormal sperm can have different shapes of the head, midpiece, and tail. And it's important to recognize that sometimes tobacco, marijuana, CBD oil, lots of artificial sweeteners, heat to the testicles, also environmental factors such as plastic and pollution can affect these issues. And so it's important to talk it through, look at the medications the male may be taking. Sometimes some of their prescription medications may be impacting the semen analysis. And so studies indicate that 25% of infertility is primarily male factor, and 40 to 60% of it, of all the couples we see, there's a component of a factor of on the semen analysis, but we never trust one semen analysis. We usually repeat it. And we usually talk about lifestyle modifications while we're trying to optimize the sperm quality too. Next slide. We do a holistic approach here at Southern California Reproductive Center. We have an acupuncture team downstairs on the first floor. I used a lot of acupuncture when I was trying to get pregnant. I think it lowers cortisol, and it also helps some people take a moment to really tune into their body, understand to improve their sleep patterns, as well as discuss any concerns they have with our acupuncture team. We talk about nutrition. It's really important. Some of our patients are not having a well-balanced diet. So we talk about Mediterranean diet and meditation, mindfulness, journaling, anything that can kind of break that fear factor in that cycle. And we use a multidisciplinary approach. We work really well with our urology colleagues who help us optimize the sperm health, the primary care doctor, again, to make sure your annual physical exam's up to date. We really want to help you get a healthy pregnancy and healthy journey through your fertility medications. Next slide. In terms of the benefits, it's important to, like I mentioned before, have whole grains, veggies, legumes, fruits, vegetables, the Mediterranean type of diet. We really want folic acid or a prenatal vitamin for 3 months before you start to try to get pregnant to prevent spina bifida. We talk about B12, some medications for polycystic ovary syndrome patients, they're on metformin, it can lower B12 absorption. So it's important to amp up foods that have B12. Talk about omega-3 fatty acids. That's really helpful for sperm quality as well. Next slide. Supplements, I mentioned it too, but prenatal vitamins, CoQ10, which helps the mitochondrial function of the egg as well as sperm, and vitamin D as well. There are many, many papers that prior to pregnancy, if your vitamin D level is optimal, there's a safer and healthier pregnancy as well, less inflammation. Next slide. It's important to avoid toxins. Over drinking can affect egg and sperm quality. So we usually say to limit it to less than 4 drinks a week, but during the IVF process or egg freezing process, we don't allow any alcohol. And cannabis also can have some ramifications on the hypothalamus, especially for men, and it can have an impact on sperm qualities for some people. And so it might have toxins and things in it. So it's always hard because some people say, I want to sleep better and I'm on this to help me sleep better. And then, so it's a well-balanced diet, everything in moderation. That's really important. But tobacco has been shown to cause early menopause and lower ovarian reserve or egg supply. And it also does have an impact on sperm motility. And you're hopefully going to have a baby soon if you're trying to conceive. So I always say it's good to really optimize your health for the future baby's health as well, too. Next slide. I'll pass it on to my partner, Dr. Surrey.
Thank you so much, Carolyn. That was an excellent summary that points out the fact that, this is a holistic process that includes your general health. And, Dr. Alexander was very correct in her presentation of issues that we create ourselves by ingesting toxins and things of this nature, and things that we can do with our diet and our health to improve our fertility. There are things that we can't do, and that is get younger. Although we can try, but there is a direct correlation between normal human fertility and chronologic age. And that really speaks to the genetic content of the eggs that we produce as human beings. And you see how rapidly normal monthly fertility can decline in the 30s, which is the reason why we're going to speak a little bit about fertility preservation today, because whatever is going on now is better than it's going to be in the future in regard to fertility. So it's important to try to understand that we do have technologies now that work very well to preserve your fertility for the future. Next, please. So this is a normal phenomenon that not only has to do with the genetic quality of the eggs that are produced, but also the number of eggs that are produced, which decline rapidly after puberty and essentially stop somewhere around menopause. So you'll notice that there is in the human ovary a lot, not many at all at age 50, for example. Next. So when we look at preservation of fertility, we know that many of the eggs that may be produced are not going to be able to create a normal pregnancy, so that more is better. And we're able to stimulate the ovaries to make more eggs with naturally occurring releasing factors that are produced by your pituitary gland that include things like follicle stimulating hormone and luteinizing hormone. And these are given underneath the skin. So they don't come in an oral form. And so when people talk about fertility injections, this is what they're speaking about. They are in an insulin syringe. So I don't know if anybody has ever known a person with diabetes, but it's something that you give yourself. And it's really fairly innocuous. So I know that nobody likes little needles, but it is something that works really well. And most people, even though they're not in medicine, are able to do this themselves. And it takes, on average, about 10 to 14 days of the medications to be able to produce mature ova or eggs that can be preserved. During this time, we like you to be available so that we can see your response to the stimulants with ultrasounds and hormone levels that we, on average, will want to do 4 or 5 times during the cycle. The eggs are actually aspirated with some sedation. It's not a general anesthetic. And it takes probably 15, 20 minutes to do that, after which you'll go home. Next. This is what things may look like if you're a high responder, meaning you have a good AMH level, a good ovarian reserve, and you see these little circles. They can contain eggs. On their retrieval, if you'll notice, there's a little needle that goes into each follicle to aspirate the egg. Next. The eggs can then be stored by a process called vitrification, which is like a flash freeze. And it used to be many years ago that eggs didn't freeze well because they were frozen with a slower mechanism. And as you might think, eggs have a lot of fluid in them, probably more water than most other cells in the human body. And as such, they're sensitive to crystal formation, and we avoid that with vitrification technology, which our lab is very well versed in. And the eggs are stored on site in places where we routinely, on a daily basis, will check their viability and their status, so that people will think, well, gee, what happens if the power goes off? Well, we have backup generators. We have lots of safety procedures for your gametes or your eggs to make sure that they're safe. Next. So it's possible to produce embryos from eggs at any time, either initially, if you look at the sperm entering into the egg, what will then happen is the egg will start to divide. And you may recall Dr. Alexander mentioned that our is well versed in the formation and evaluation of blastocysts. A blastocyst is an advanced staged embryo that can be evaluated for its normalcy to cause a pregnancy. Next. This fertilization process can be done either initially, if you have a partner, and preserve your fertility by preserving embryos, or in the future, when you decide that you have the right situation. It doesn't matter when you choose to fertilize your eggs. And if you do create embryos, it doesn't matter when the embryo is implanted. It's so much as that it can remain in a vitrified state for many years without any damage. Next. Here is what Dr. Alexander was mentioning. It's a technology that allows us to look at and evaluate and observe embryo formation without actually disturbing the embryo. This is a video that's taken underneath the incubation system. And this is a blastocyst now, which is over 100 cells. And it's able to be fully evaluated as a normal blastocyst, which is capable of creating a normal pregnancy and also capable of being genetically evaluated before you get pregnant, which maximizes the chances of a pregnancy and minimizes the chances of a miscarriage or a genetic issue. Next. So that when we look at the outcomes of preservation, firstly, there is a thaw survival rate of over 90%, a fertilization and cleavage rate of over 80%. And when we look at our pregnancy rates, they're very, very high. Next. They're higher with younger people, but if you look at the fertility rates which we have, which are in the blue column, compared to national averages, which are the tan column, ours are much higher in our laboratory and are very good even for older patients. But this, again, is not spontaneous fertility. This is fertility with the aid of this technology, which actually creates a higher than usual fertility rate. So I hope that this information has been interesting for you. And as Dr. Alexander mentioned, we're very happy to speak to anybody who would like to have any questions or comments, either by phone or in person. There are different promotions that exist that you could visit the website to get details about. Next. This is our group for the moment. And Dr. Alexander looks like she's 18 and Dr. Maxwell looks like she's 14, but and Dr. Danzer and I are a little older. But we're all happy to see you. We're all experienced in the processes that Dr. Alexander alluded to, and we're happy to answer any questions that you might have. So if you'd like, we could open up to comments or questions for a little bit.
One of the questions, Dr. Surrey, was because I mentioned annual pap smear and physical. Do you have to have that done before the initial consult? Do you want to answer that one?
You know, we like to have our patients, as Dr. Alexander mentioned, you know, be evaluated for their general health, which includes sometimes a physical exam, which we can assist in because we have a laboratory here that's able to obtain hormone levels and blood counts and things within an hour of drawing your specimen. But it's nice to have an internist or a family doctor who you can see as well. We like you to have a gynecologist who can check your pap smear. So, you know, it's not essential, but it's helpful. So
Yeah,
there are a
I
couple
think
of questions
it's
here.
not mandatory before, but one of the questions was how many eggs should I have prepared to have to be frozen at age 37 for the goal of one pregnancy? And I think that's such a good question because here we've seen people have less than 10 eggs and get 2 good pregnancies, and we've seen people have 20 eggs and not get a healthy embryo. And that's where preparation for the sperm, when you plan to thaw those eggs, is really important. As Dr. Surrey always says, you know, 90 days or over 70 days to prepare for the man to avoid marijuana, avoid vaping, tobacco, hard alcohol, artificial sweeteners, all those good things. So it's very important to think about that. But our embryology team did an analysis at age 37. We needed 17 to 20 eggs to get one pregnancy. And that's with a mixed group of semen analysis, because sometimes it's a male factor that we can't remedy. And so it's important to recognize that sometimes those eggs are thawed and we take the sperm we can get and we do the best we can with that. And that may or may not give a good embryo, but we try the best we can. So it takes a lot of eggs to get a pregnancy. When we're under 35, it's a little bit easier from the chromosome issue, because as the egg has a mitotic spindle, which is like a spider web, when it separates the chromosomes, it's less sticky and less problematic when we're under age 35.
So
Dr.
there are questions. Dr. Alexander, do you want to maybe
I'll ask you this one's a good one. Is there any age or AMH cutoff for egg freezing? I always think that's a good question.
you know, everything's different. If you look at this with the idea of chronologic age, you know, some people use the number 40. We don't like to use a number because we like to individualize our treatment plans for people. But by and large, as we age as human beings, the genetic quality of the eggs that we produce, as we've discussed, decreases. So when we think about fertility preservation after 40, it's usually more accurate if you can fertilize the egg, create an embryo, and then you know what you have, because it's possible at 42, let's say, to create eggs and not have them be of use to you. And it would be a shame to do that and not be informed or accurate of what you're doing. So there is a number, and everybody's a little different as to what that number is. But AMHs, as Dr. Alexander mentioned, are markers for the number of eggs that you might create. So as we age, the more is better, because many of them are not going to work. So we'd like you to have a good AMH number if you're going to have a chronologic age that is approaching or over 40.
Yeah, I totally agree. The next question, do your chances of getting pregnant spontaneously or naturally decrease if you froze your eggs? And interestingly, in the 1980s, when women were donating their eggs, they were in their 20s and donated their eggs, they monitored them, and they still hit the average age of menopause, which is 51, and they still had general healthy fertility levels. And so we didn't see a dramatic shift. And what's fascinating is the ovaries have a pool of follicles every month that are available to recruit with the medications that Dr. Surrey mentioned. And that marches on to the next month, another pool. So if you froze 10 to 20 eggs 6 months ago, it doesn't mean you've depleted your current pool of follicles. So that was a really, really good question. I have a question for you, Dr. Surrey. Is ICSI advised for a successful embryo?
That's a good one. You know, there are a lot of labs who feel that way, and there are reasons for that. ICSI means intracytoplasmic sperm injection, where a single sperm is injected into a single egg. And it does, in fact, increase the accuracy of fertilization, because if you just put an egg with a lot of sperm, there is no way to know which sperm, and if more than one, may get into and fertilize an egg. And it's actually not healthy for more than one sperm to fertilize an egg. It doesn't produce a normal embryo. So the ICSI process actually does increase the accuracy of fertilization. Now, do you have to do that? Usually not, but there are men who have very low volumes and numbers of sperm for which the ICSI is essential in order for fertilization to take place. So the bottom line with the ICSI is that it can help many people. It's necessary in a few people, but it does improve accuracy.
Mm-hmm. And on that line of questioning, there's a question, does sperm morphology with high abnormal forms have an impact? And some people speculate that as the egg tries to be fertilized, there has to be hypermobility of the sperm to penetrate through the zona pellucida. And if the shape of the sperm is unhealthy, sometimes it can't properly get into the egg to fertilize the egg. Some people wonder if dipping that egg, like Dr. Surrey mentioned, with 20,000 sperm, what if the unhealthy one went in? But generally speaking, we listen to the couple or the patient if they want to do ICSI, and we talk about the pros and cons of some of the eggs to not do ICSI, but we do see occasionally in those eggs that they don't fertilize. And so that's always our fear. You could have the best group of eggs, but if there isn't proper fertilization, it's hard to make an embryo and a blastocyst to use to place inside the uterus for an embryo transfer.
Correct.
I
was going to
one of the
mention
questions was what factors contribute to how many cycles of egg retrieval is needed?
You know, I think it gets back to what your goal is and what your results are. So we may have spoken to the effect that, you know, more is better. And depending upon your age, there are an average typical number of eggs that we would like to see to create a normal, healthy pregnancy. And just arbitrarily, for the average age of our patients, which is in the upper 30s, that number is around 10 or more. So if you preserve your fertility by preserving unfertilized eggs, and you only create 5, then, you know, we probably want you to do it again. If on the other hand, you produce 20, maybe you don't need to. So it's a very individual answer depending upon what your goals are. If your goals are to have multiple pregnancies, then you need more eggs.
And one of the questions is it better to have eggs or embryos? And another question asks about if you're not ready to pick a sperm donor, but you're older, what should you do? I think it's always a very important discussion with your doctor. Your doctor will look at your ovarian reserve levels, your follicle count on the ultrasound, try to understand with you your personal goals, you know, and your life goals. So I think ultimately An embryo is always going to be stronger than an egg for a biological baby for you for the future, because the egg may or may not survive the thaw or fertilize or be genetically healthy. But if you're not prepared to choose a sperm donor, that's kind of a big step to take in an involved process to help you pick an optimal sperm donor for you specifically. But some patients do half eggs, half embryos, or they'll do one wholehearted try of eggs, see how the eggs come out, see how the retrieval goes, and then they'll do a cycle of embryos so that they have a balance or an option for the future as well.
It's a good idea for a lot of older patients because the problem with the older patient who makes a small number of eggs and does not fertilize them is when the time comes to use them, they may not find the answer that they like in regard to a normal embryo. So, that's why the idea of fertilizing the egg, even if you don't know the donor that you want, is going to give you much better information about the potential of that egg creating a pregnancy in the future. And so Dr. Alexander's idea about maybe doing 2 different cycles, one where you use a donor to fertilize eggs and another where you don't, is probably going to be helpful in that regard.
One of the questions is, what happens if my AMH is lower than my age group would predict? We have to look at the 3 main reasons why. And so it's important to talk to your doctor about why is that happening and think it through. So there are some tests we would encourage and think through. Also, we talk about lifestyle modifications and things like that to try to at least help stabilize it. And it isn't a perfect test. So I always tell patients we can't change the past. So you can only look to the future, and you have to sort of make an action plan and a treatment plan with your doctor and try to figure out what's best for you. But worrying and thinking, why didn't I do this sooner? And those concerns, I always feel like that just sort of drains your energy and your life force. You just have to look to the future. It was never chosen as a perfect test. In the early years of fertility, we didn't have AMH, but we use it a lot now. But it's not like we said, it's not a perfect test. So don't be too alarmed, because worrying is not going to help that level as well.
One of the nice things about the AMH is that unlike the FSH, you don't have to be day 2 or 3 of your cycle to have it be revealing and give you good information. So you could do it as part of your checkup when you go to your gynecologist, even if you're in the middle or the end of a cycle.
Yeah, thank you for such fantastic questions, and we hope to help in any way possible through this discussion. And it's been joyful. And thank you to our team, Brittany and Sissy, for putting this all together for us and keeping us on time. We really, really appreciate your hard work and dedication to us. And we're all here for you and wishing you all the best. Thank you.
So if anybody has any additional questions, any of us would be pleased to chat with you in the form of a remote kind of a phone consult or a consult in person. So we're very happy to have had the opportunity to meet with you all, and we'll look forward to hearing from any of you if you'd like.